Good afternoon, everybody. Welcome to the webinar organized by EASD Early Career Committee. Let me introduce my co-moderator, Dr. Ilke Sen, a basic researcher and a group leader from Mondor Biomedical Research Institute in France. And my name is Agata Grzelka-Woźniak. I'm a medical doctor and a PhD from Poznań University of Medical Sciences in Poland. I would like to cordially welcome Professor Ewelina Tankova, who will present today's webinar about the 2022 ADA-EASD Consensus Report on the management of hyperglycemia in type 2 diabetes. Professor Tankova is a professor in endocrinology. She's head of the department at diabetology at University Hospital of Endocrinology in Sofia in Bulgaria. She's also a chair in endocrinology at the Faculty of Medicine at the Medical University there in Sofia in Bulgaria. She's also an author of the EASD and ADA Consensus Report on the management of hyperglycemia in type 2 diabetes, which she will be discussing today. She's also a member of Guidelines Oversight Committee at the EASD and an expert on endocrinology at the Bulgarian Ministry of Health. Her main interests in the field are in the field of prediabetes, obesity, metabolic syndrome, glucose variability, prevention, and complications of diabetes. Now, Professor Tankova, I hand over to you.
Thank you very much. Thank you very much, Agata, for the kind introduction. And I would like to thank the Early Career Committee at EASD for the invitation to be together today and to share with you what is new in the recent 2022 ADA EASD Consensus Report on the management of hyperglycemia in type 2 diabetes. So once again, thank you very much. And I will go directly to the topic. It was a great honor and a great pleasure for me to be invited to be part of the writing group preparing this consensus report. It was in 2021, and for 1 year the group was working quite hard to prepare this consensus report. It was a pleasure, it was a great honor, but I may share with you that it was a great responsibility to be part of this writing group. This is the publication which came out in September 2022, immediately after the presentation at the EASD annual meeting. So this is these are the members of the writing group. The writing group was co-chaired by Professor Melanie Davis from the University of Leicester and Professor John Buse from University of North Carolina. And it was a great pleasure working with them. Also, we had the two presidents of EASD and ADA, Professor Stefano Del Prato and also Professor Robert Gavey. And this is the group of 10 colleagues who had to do the main work. 5 from Europe, appointed by EASD, and 5 from the United States. So from Europe, I was working together with Peter Rossing, together with Geltrude Mingrone, with Apostle Sapos, and Professor Chantal Mathieu. So what was the reason to prepare this consensus report in 2022, starting in 2021? In fact, we had the consensus report from 2018 and the update from 2019 as a starting point. So we did search a lot of papers, a lot of manuscripts, a lot of randomized controlled trials, reviews, meta-analysis, which were published between January 28 in 2018, beginning of 2018, till mid-June in 2022, but we had to add some information up to September 2022. It is really a consensus report, as you see from the title. It is evidence-based, but you need to take into consideration that it is reflecting the values and the preferences and the opinions of the author, but it is an evidence-based document. And it was really a hard work. I was invited in September, in the autumn of 2021, and we started working during the COVID time. It was working online. We had online meetings. We had to consider the time difference between the United States and Europe, and it was quite challenging, but we did work quite hard. We had to meet in Washington somehow in January 2022, but it didn't happen. We worked online for 3 days. Then we met in Amsterdam in April. And then when we were approaching the ADA meeting in 2022, we were working online almost every Friday. And in fact, we prepared the draft consensus, which was presented at the ADA scientific sessions in June in 2022. So it was a draft consensus. And thereafter, we got over 450 different comments on this draft, which we had to consider, which we had to give answer to decide whether to include in the final version or not. And it was really a very exciting period just to see how people from different companies, our colleagues from different parts of the world, some reviewers which were invited by Diabetes Care and Diabetologia, the ADA Professional Practice Committee, the EASD Committee of Clinical Affairs. So we had to consider them, and finally we came to the final presentation, which was during the EASD annual meeting in September 2022. So my idea is now just to tell you some new, what is new with this consensus report. In fact, why we had to prepare this update on the consensus report. Between 2018 and 2021, there was a lot of new evidence. There was primary evidence which came from cardiovascular outcomes trials, heart failure trials, renal outcomes trials. You see quite a number of them being mentioned here, but also there was a lot of secondary evidence. There were a lot of subgroup analysis, post hoc analysis, meta-analysis, network meta-analysis, a lot of papers we had to go through. And finally, we came to the final version of this consensus report. And because it is a consensus report on the management of hyperglycemia, we are all mostly interested in the new therapeutic options. But to come to the therapeutic options, we need to go first through the lifestyle and healthy behavior. And in fact, I was responsible for this part of the consensus. This was one of my obligations, one of my duties there. And that's why I like this really very much. Because as you see, usually we speak about physical activity in people with diabetes, but you may see here, the title is physical behaviors, which is really, really very important, because we do not need to consider just the physical activity during the day, but we need to also consider our physical behaviors, which come really during the night. And you see here on this infographic, 5S, sitting, sweating, stepping, strengthening, and sleep. And it all comes about our physical behaviors. And I will very quickly go through this nice infographic, just to tell you that sitting appears to be quite important. We need to break up prolonged sitting, and if we do this, we can improve glucose metabolism. Sweating is also important. What does it mean, sweating? It means moderate to vigorous activity. And in this consensus report, we do recommend, we do encourage over 150 minutes per week of moderate intensity physical activity or over 75 minutes of vigorous intensity activity. But these should be spread over at least 3 days a week with no more than 2 consecutive days of inactivity. And it is always very important to consider the frailty phenotype of people with type 2 diabetes, because the ability of people with type 2 diabetes to undertake even every day, even simple exercise in middle age is similar to that in people without diabetes who are over a decade older. This is really important. The frailty phenotype should be considered in people with diabetes. Stepping is important, and we encourage people to increase the number of steps per day. And it appears that there is evidence that if we increase just by 500 steps per day, we can decrease the risk of cardiovascular morbidity and even of all-cause mortality. And what about strengthening? These are the resistance exercise, which appears also to be very important and to improve glucose control, to improve insulin sensitivity. But up to here is the physical activity, which we are all aware that is very important for people with diabetes. But what's really very important is that for the first time, sleep is included in a consensus report on the management of hyperglycemia in people with type 2 diabetes. And it appears that both the quantity and the quality of sleep are important. There is evidence that both long sleep, it means over 8 hours, and short one, below 6 hours, they can have a negative impact on hemoglobin A1C and also the quality. We need to have to recommend, to stimulate, to encourage uninterrupted sleep, consistent sleep, because irregular sleep has a negative effect on the management of type 2 diabetes. And also the chronotype, which was quite interesting for me when I went through the literature, that the evening chronotypes, the so-called night owl, these are people who are more susceptible to inactivity, to poor glycemic control, than those people who are the morning chronotypes, the so-called early bird. So we need to consider that really sleep is very important. And when we discuss with our patients about physical activity, we need to touch upon sleep as well. But we need to come to the pharmacotherapy in people with type 2 diabetes. And you see how these medications, glucose-lowering medications, have been positioned in this consensus report. The two groups, the modern drugs, called the cardio-renal protective glucose-lowering medications. We have the other glucose-lowering medications, which are all the others, and some less commonly used, like alpha-glucosidase inhibitors, glinides. And what is most important from this consensus report is this holistic approach for the management of people with type 2 diabetes. The person with type 2 diabetes is in the middle, and in the goals of care are to prevent complications and to optimize their quality of life. And there come the 4 main components of care. Just to tell you that all these 4 components of care, the glycemic management, the weight management, the cardiovascular risk factor management, and the cardio-renal protection, these are 4 main components of care for people with type 2 diabetes, and these are positioned in a circle, which means that none of these is more important than the others. They are equally important, and we need to target the 4 of them in the process of care for people with diabetes. And there come the so-called principles of care, 13 of them have been included here. I will not go in detail through them, but just to tell you, there is one quite important there. We need to avoid the therapeutic inertia. Yes, we have experience with a number of drugs before these new drugs have come to our clinical practice, and we need to overcome this inertia and prescribe our patients what they mostly need. Language matters is also important, the psychosocial factors. To consider the social determinants of health is very important. So that's it. This is the holistic approach with the main components and principles of care for people with diabetes. These people who have type 2 diabetes, they are throughout all these documents called people with diabetes because they are normal people. They are not ill people. They are just people with diabetes. And what is very important, I will start with the medications for management of glycemia, for the glucose control. It is quite important that we need to start here and to choose approaches that provide efficacy to achieve our treatment goals. And you may see here we have metformin, but metformin is here, but metformin is not alone. We have either metformin or any other agent or agents, including combination therapy, to provide the efficacy to achieve and maintain the goals. Because there were some assumptions that metformin is no longer the first-line choice of treatment, it is not the case. Metformin is there, but metformin is not alone. Metformin is there with all the other options and even with the combination therapies. And it is for the first time in guidelines, in consensus report, that the glucose-lowering medications have been stratified according to their efficacy for glucose lowering. And you see, we have here medications with very high efficacy, dulaglutide, but just the high doses, semaglutide, tirzepatide, insulin, and all the combinations. We have medications with high glucose lowering efficacy, which are the other GLP-1 receptor agonists, metformin, SGLT2s, SUs, T2Ds, and we have medications with intermediate glucose lowering efficacy, and these are the DPP-4s. We now go to the management of body weight. Of course, we need to encourage medical nutrition therapy, evidence-based structured weight management programs, but of course, medications for weight loss, of course, metabolic surgery. And when we choose glucose-lowering therapies for people with overweight and obesity, we need to consider those which are with high to very high glucose and weight-lowering efficacy. And again, for the first time, medications for glucose lowering have been stratified according to their efficacy for weight loss. And we have such medications with very high weight loss efficacy, semaglutide, tirzepatide. With high one, these are dulaglutide, liraglutide. With intermediate efficacy, the other GLP-1s, SGLT2s, and we here have also the other medications. And what about the management of cardiovascular risk factors? We are all aware that we need to target blood pressure, lipids, antithrombotic state, smoking. So the management needs, we need to screen and we need surveillance for the cardiovascular risk factor management. And I've come to the cardio-renal protection, which is as important as all the other components of care for people with type 2 diabetes. And we have here three main groups of people with diabetes. Those with atherosclerotic cardiovascular disease or with indicators of high risk, those with chronic kidney disease, or those with heart failure. So I will start how to choose glucose-lowering medication for people with cardiovascular disease, whether with established disease, whether with high risk. And we have two options here. But if we do not achieve the targets, you see that down here we have another option. And strangely enough, it is the TZDs, because we have some evidence for this group of medications. And what do these consensus tells us? What are the recommendations? I have put in bold here should, because it's quite important. The wording of the consensus recommendations is really very, very important. What is the recommendation? In people with established cardiovascular disease, a GLP-1 receptor agonist with proven benefit should be used to reduce MACE, or an SGLT2 inhibitor with proven benefit should be used to reduce not only MACE, but also heart failure and to improve kidney outcomes. We have quite strong evidence here. That's why we have put the word should here. But if the word comes for people without established cardiovascular disease, but with multiple cardiovascular risk factors, obesity, hypertension, smoking, albuminuria, dyslipidemia, then the same medications could be used. And this is because the evidence here for those people without established cardiovascular disease, this evidence is not that strong as it is in people with established cardiovascular disease. And what is very important, and we need to consider in everyday clinical practice, is that people with heart failure, chronic kidney disease, established atherosclerotic cardiovascular disease, or multiple risk factors for cardiovascular disease, we need to choose a GLP-1 or an SGLT2 inhibitor with proven benefit independent of background metformin use and independent of the hemoglobin A1C of the people whom we are treating. So this is really very important. We don't need to consider metformin or hemoglobin A1C. We need to go directly to these medications because we should use them in some of these populations. What about people with diabetes and heart failure? Here we have again the wording of should, because we have enough strong evidence in people with heart failure. We should use SGLT2 inhibitors to improve heart failure and kidney outcomes. What about the people with chronic kidney disease? Here, of course, the choice comes, and we should prescribe SGLT2 inhibitors to reduce MACE, heart failure, and kidney outcomes. And you look what was written in 2022. If such a treatment is not tolerated or is contraindicated, then a GLP-1 with proven benefit could be considered. I think that in the update of these guidelines, this will be changed because we now have enough strong evidence that GLP-1 receptor agonists should be used because we have evidence from some of the trials. So this is very important, and that's why this consensus report needs an update. And this is the so complicated infographic with all this information which I just showed to you. How to manage glucose, how to manage body weight, how to manage the cardiovascular risk factors, and also how to manage people with already established chronic kidney disease, atherosclerotic cardiovascular disease, or heart failure. It looks like complicated, but I think it's quite concise, and you can find whatever you're looking for here to manage people with type 2 diabetes. This is, of course, the table, and we have now for the first time a table which on the top has just healthy lifestyle behaviors, self-management education and support, and considering social determinants of health. And then we go either to people at high risk, or we need to manage and maintain glycemic and weight management goals. And it is quite nicely structured in this figure. And we have no longer a choice up there on top of the table. We have different options according to the individual characteristics of our patients with diabetes. We can choose from one or another option. The combination therapy is quite reinforced in this consensus report because there is a lot of evidence and rationale for this combination therapy regarding the durability of effect, the potential to address therapeutic inertia, and of course the complementary clinical benefits, which is really quite important. But what is really very important is there are some words about the different populations of people with type 2 diabetes. One of them is the older people with diabetes, and we need to select medications to improve cardiovascular and kidney outcomes, not different from that for other people at other age. And for young people, it is very important that in this consensus report, people below, it was outlined there that people at the age of below 40 years, these people have been underrepresented in the big randomized control trials. And it appears that these people who are diagnosed below the age of 40, they are really at very high risk for complications. They need to be treated aggressively, correspondingly, and unfortunately, these people have more rapid deterioration in glycemic control, and that's why we need to be very, very aggressive in these people, and we need to look to and to achieve the targets and to maintain these treatment targets as early as possible. And one quite important part of the consensus report, which I would like to share with you, these are the practical tips for clinicians, because none of us wants to read pages and pages to come to a certain keynote message. The practical tips for clinicians, I will very quickly go through these. This is the importance of integrated care, that we need to acknowledge the lifelong and the evolving nature of type 2 diabetes. We all need to work in a team. We need to consider the local resources and to remember that language always matters in diabetes care. How we speak with people with diabetes is really, and how we address them is really, really very important. It is very important to individualize the care, to consider each person as an individual, to consider the inequity in the delivery of interventions because the settings in which we are all living are quite different, to address always the social determinants of health, and of course to consider the comorbidities, the complications of people with diabetes. So individualization is really, really very important. It is very important for us when we choose pharmacotherapy to be quite aware about the benefits, about the risks of the different pharmacotherapies. We need to identify the comorbidities of people with diabetes, to assess the profile of people with diabetes, to consider the risk factors and the side effects of the different medications, and always in our everyday clinical practice to prioritize the organ protective medications. And look here are the GLP-1 receptor agonists, here are the SGLT2 inhibitors, but here are also the thiazolidinediones. What about the place of insulin? We already know where is the place of insulin in the current consensus report, and that we need to use other injectables before insulin. But something very important, which is here in these practical tips for clinicians, is that when insulin is initiated, we need to continue the organ protective glucose lowering medications and metformin. So this is really, really very important, and we need to educate these people when we initiate insulin. But its position of insulin, the place of insulin, is not that much prioritized in this consensus report because we have much better options for people with type 2 diabetes. Not to say that we need to skip insulin, that it's not important because it's a life-saving medication, but still it's not that prioritized as a first or second choice in people with type 2 diabetes. And you know that technology is quite widely used in people with type 1 diabetes, but when we speak about type 2 diabetes, it is for the first time that in a consensus report technology is also mentioned here. And it is pointed out here that we need to consider continuous glucose monitoring for this, at this point, 2022, in people with type 2 diabetes on insulin. But I think with the update of this consensus report, probably we will widen this position and use of technology in people with type 2 diabetes. So technology appears to be quite important. It can be useful in people with type 2 diabetes, but technology, it is very important. It has to be part of the holistic approach for people with type 2 diabetes. And to end up again with this nice figure, which I like really very much, this is the holistic approach. This is the most important point in the consensus ADA EASD consensus report from 2022. And just to share with you that now we are in a process of preparing, organizing the work of the writing group. I'm again honored and privileged to be part of this writing group to prepare an update of this consensus report, because a lot has happened since mid-2022. We have data from new trials, we have new evidence for this, I would say, quite long period of time for diabetology. That's why we will prepare a new update, hopefully to prepare for 1 year from one on, and to be able to share with you in 2026. So again, the main focus now, the goals of care, the person with diabetes in the very center, always considering the two main goals, the quality of life. We do not need to forget that these people need to live as normal people their life, and to prevent the complications, of course. We need to target glucose, weight, cardiovascular risk, and cardio-renal protection equally. We need to consider a number of principles of care, and then we need to really follow the evidence and what is written in the guidelines about choosing glucose-lowering medication, choosing the approach for weight management, for the cardiovascular risk factor management, or when we need to treat people who already have heart failure, chronic kidney disease, atherosclerotic cardiovascular disease, or other high risk of developing atherosclerotic cardiovascular disease. So this is what I had prepared for you, and because I come from Bulgaria, from Sofia, and Bulgaria is the country of roses, so these are some roses from May from Bulgaria, with which I would like to greet all of you. And I'm open now for questions and for discussion. And if you have any questions, I'll be very happy to answer you. Thank you very much for your attention.
Thank you very much for your great talk, Professor Tankova, and sharing this valuable information with us on the management of hyperglycemia in type 2 diabetes. I'm sure there will be some questions from the audience, so I would like to open the session for question and Q&A. You can either ask the question by unmuting yourself, or you can also write your question on the chat. We can ask the question on behalf of you. Are there any questions? I can start with one while people are making their minds about the question. So my first question is about the the sarcopenia in type 2 diabetic patients, which is a concern. And I would like to get your opinion. How do you think we should adjust these pharmacological strategies to minimize further loss while maintaining the adequate glycemic control? Because especially there's evidence within the new drugs, the administration of the new drugs, it's also exacerbating sarcopenia in these patients. What will be your thoughts on that?
Yeah, you saw that it is one of the main issues when we address people with type 2 diabetes, the frailty phenotype, the risk of sarcopenia, which is per se typical and important, and it is there in people with type 2 diabetes. But when we are putting forward all these new medications, and especially the GLP-1 receptor agonists, which we know people can lose weight, but they do not lose always fat mass. They lose their lean mass, their skeletal muscles, and we see this in everyday clinical practice. That's why many times we choose and we prescribe these drugs, not reinforcing the importance of physical activity behaviors. Of course, sleep is important, as I already pointed out, but you see that everyday physical activity, the different forms, the stepping, the strengthening, whatever written there, the sweating, the vigorous, the moderate intensity physical activity. We need to stimulate people. We need to educate them. We need to teach them how to take the medications, but also what to do and how to manage their physical health, because this is really very important. What happens sometimes? People get the medications, they inject themselves, they lose weight, they do not practice any physical activity, and finally they lose weight, but they lose their lean mass, which is really a big issue. It is part of the effect of these GLP-1 receptor agonists. And even now there is a whole strategy what to do, how to minimize this effect of the GLP-1s, whether to develop new medications just to stop this process when prescribing GLP-1 receptor agonists. But I think that there is a much more simple way, and it is if we advocate, if we encourage the physical activity. But always consider the frailty phenotype and the risk of sarcopenia for people with diabetes, even without the GLP-1s. But with GLP-1s, the situation becomes much more complicated.
Exactly. Yes, thank you so much. Are there any questions from the audience?
If not, in the meantime, I would like to ask you, Professor Tankova, what is your favorite S? You said that you were responsible for the guidelines, for this part of the guidelines. And by that, I mean, what would be most relevant for our patients?
It was in fact at the beginning we started to think about how to, because always there is the diet, the nutrition therapy, and the physical activity part in all and each guideline and consensus report. And then it came out that there is a lot of evidence already on sleep. And we started thinking what the different physical activities, and it came out that all these started with S. And it was nicely prepared by the team in Leicester in this nice way with the 5S. I was also impressed by the evidence on the different types, for example, on breaking up sitting, which we do not consider that important. We usually consider going to the fitness, different forms of physical exercise. But speaking frankly, what was almost new for me before searching and going through the literature was the sleep. I was not aware. Of course, I had some idea about that sleep is important, but I did not know that there are so many publications on this, and that it is such important for our behavior during the day, because it's not just during the day, it's the night. We are always very busy. We don't count on sleep. Sometimes I think in the majority of cases, it's the short sleep, which appears to be quite dangerous for our metabolic health. But I was really surprised by the long sleep. And there are some publications. What is long sleep? whether it is over 8 or over 9. There were different publications there, and finally it came out that maybe over 8 is not that good, and that's why we put below 6 and over 8. And then the chronotypes were also quite interesting because I think the majority of us as physicians, as clinicians, are maybe not the early birds, but the other chronotype, the night owl. So it was really very interesting for me, and just to share with you, because I'm discussing something which it was not my only task there, but it was one of the tasks, just to tell you that each and every word in this consensus report has to have some evidence behind it. You cannot put a word there in the consensus report if you don't have strong, or not that strong, but if you don't have evidence there. So I realized when being involved in this activity that really every word counts and that really language matters. How to say something either in front of a person with diabetes or in such a consensus report is very important. I just pointed out should and could, which is important. It demonstrates how strong the evidence is. So from this point, coming with a lot of words to the answer of your question, it was really a very interesting, because it's something new. You always want to make something new, to present something new, and I did present this part really with great enthusiasm, because I knew it is new for the colleagues, for the clinicians, and I think we changed our communication with patients. And when, for example, when I or my colleagues, when we discuss some issues in the management of diabetes, we do mention the sleep, which is really very important. It can be one of the reasons for poor glycemic control, and we need to stress upon it. And to let room for other questions.
Yes, I can see 2 questions in the chat.
Okay.
One of the first one is from Sahar Iqbal. Sahar, if you want to ask your question by yourself, also you can unmute yourself and ask a question. If not, I'll ask the question on behalf of you. You're here.
Yes, hi,
Please.
Thank you so much. This was so enjoyable. I remember being at the ADA in 2022, listening to the new guidelines, and obviously we expected, of course, this was going to progress and we are going to have some more information, more data. I think the biggest, and when you practice clinically, the biggest thing that you come across from a practical standpoint is access to medications, and GLPs have been very difficult to access. So I'm in North America, I'm in Canada. And the insurance companies are very stingy. They don't want to give these medications to people. I've had patients who have diabetes fight with patients with obesity about, oh, this is for a disease. Why are you taking it? Why do you have access? And I don't know what, as physician, I mean, you can clearly see the data is clearly showing what we should be doing, and certainly the guidelines will reflect all that. But I don't know if the governments are following or if the insurance companies are following our data. How can we advocate for this, and how do we change that culture? I think we have a lot to go on. That's one thing. And the other, I feel, the placement of metformin. I think if you look at the ADA guidelines, if you look at the Canadian guidelines, we're still lagging. We're still saying metformin is first line. I really have huge concerns about this drug. I mean, I've been prescribing it for a long time, but I know that that first of all, it has so many side effects. Most people give up after a while, and the A1C reduction is really not so impressive. And in this day and age, I think we've reached a point where we should be able to say something definitive to insurance companies, to governments, to whoever pays for these medications. Thank you.
Yeah, you are absolutely right. And thank you for raising this point, because it's really very important. These are international guidelines, international consensus report for ADA and EASD. These are somehow like a global guidelines, global consensus report. So everything which is written there is based on strong evidence, as I already told you. But the situation is totally different in the different countries, in the different parts of the world. It is a matter of access, it is a matter of availability, and a matter of affordability of these medications in the different countries, in the different parts of the world. And I'm now a member of the Guidelines Oversight Committee of EASD, and there is even a terminology now coming out, and it is development, to adapt these guidelines, to develop and adapt according to your local setting. So if you don't have this medication available, if you don't have access, how to say that this should be a first-line choice for people with type 2 diabetes? But having this consensus report, I can share the experience in my country, in Bulgaria. We use this consensus report being an international document, an international consensus. We use in the process of negotiation with health authorities, with the National Health Insurance Fund, with the Ministry of Health, and I may reassure you that it has helped us a lot, because it's really very important to demonstrate what is the evidence, because everything written there is on the basis of certain evidence, and we need to make that the health authorities think about the evidence. It is not just my opinion, or because I like this pharma company and I want to put these medications to put them forward. It is very good that there is no any intervention from pharma companies in this consensus report. It is really an objective document which has to do only just with evidence. And it is really important what you are raising. That's why one of the main principles of care is consider your local resources. It is very important. But of course, the idea is that as many countries as possible can afford this, can access this, can these medications be available. But it's a very important issue, and I do hope that this consensus report might help or should help in when negotiating with the local healthcare authorities. So thank you very much for raising this point.
Could you please comment on metformin as the first line? You know, how do you feel about that?
Yeah, for sure, yes. When this consensus was published, when the first data were announced at ADA on the 6th of June 2022, there were some comments and some rumors. Metformin is no longer there in the consensus. Metformin is there, but as I told you, metformin is not alone. It means that we are not obliged to start with metformin, despite in many countries, in many parts of the world, where it is one of the few available options, people can start with this cheap drug, which is cheap, which has an effect on the fasting plasma glucose and some other effects, of course. But from my personal perspective, I see that there are many people with diabetes who start with other options now, because they much more deserve from the very point of diagnosis to start with cardioprotective, with renal protective medications. Unfortunately, we diagnosed many people with diabetes already with some complications, already with some organ damage. So that's why I think that what was in the former guidelines, for example, in 2018, it was go for metformin, wait for 3 months, then start with some other options. I think, and we were discussing this is a waste of time. Still, there are people who would prefer starting with metformin, and they will follow the consensus report. If you do not start with metformin, start with any other option. You may start with a combination of metformin and something which will give further benefits to people with diabetes. So metformin it is not that controversial issue and treatment option. but we do not need to stay for long because the benefits of these new medications is independent of metformin and independent of hemoglobin A1C. And we are far from the glucose-centric approach. And that's why I think we need to be more aggressive from the very beginning with other options as well. Of course, if there are colleagues, clinicians who prefer starting with metformin, but don't stay there that long, despite being that cheap and accessible and affordable drug. And that's why you saw there the line starts with metformin, but there are the other options thereafter, which are too many to be considered.
Thank you very much for the question and the great answer. There's another question from Jens Lund. Jens, do you want to ask your question by yourself or?
So yeah, I can do that.
Perfect. Yes.
So my question is whether there are any areas within the treatment of either hyperglycemia or type 2 diabetes where the current treatment options are insufficient. So in other words, for us researchers, what should we focus on in the future to further improve the treatment of type 2 diabetes?
Yes, here just to mention, as you saw this consensus report, the title of the consensus report is on the management of hyperglycemia in type 2 diabetes. We now do consider that this management of hyperglycemia probably should not be the main issue in the title. And probably we need to think about management of type 2 diabetes, because the person with type 2 diabetes had a lot of comorbidities, a lot of complications, a lot of risks which are posed over such a person. And as you are asking me about what are the areas, people with diabetes have a lot of other issues as well. One of them is the liver. We have included in this consensus report the kidneys, the heart, the risk factors there. We have quite evidence now emerging on the beneficial effect of some of the medications, but not just these medications, on the liver, on the metabolic dysfunction associated steatotic liver disease. So I think this will be something new, maybe in the next guidelines, which will be focused there. We know that our colleagues from ADA have already included this in their guidelines from this year, from the beginning of this year. So this is really very important. What you are asking me, we are now we are putting some goals, and the goal is to achieve good control of glucose, good control of weight, cardio-renal protection. But what we will aim, I'm thinking about what will be the aim in the near future. Maybe we will discuss the remission of diabetes, because remission is really very important. And what does it mean to have remission? Remission is really to achieve the targets, but without medication, to maintain the targets, but without medication. If the problem is the obesity, we have targeted the obesity, we have decreased the body weight, and we have achieved the remission. So I really think that we need in the future to work for medications, for different other achievements to achieve because people with diabetes, they want to be like healthy people. They don't want to take so many drugs. They want to be in remission, and like we can get remission of some other quite severe diseases, some chronic non-communicable diseases and some other diseases as well. I would say that as basic scientists, probably we need to target the remission. It means improvement in beta cell function. It means improvement in the other organs, just to get this disease in remission. I wonder whether it will be a cure for diabetes. We usually think about this with type 1 diabetes. We are all very much eager about something like this. But really, it is It is a great challenge, and diabetology is really developing so intensively during the last decade or so. So if we speak in the areas of treatment of type 2 diabetes, there are quite many areas which we need to touch upon. As for the treatment of hyperglycemia, of course, you know, there are different mechanisms for hyperglycemia, and maybe targeting the basic scientists, targeting some of them which are emerging and which have been discovered and rediscovered during the last years will also be very important. So we rely a lot on people like you who would work in different mechanisms for the development of type 2 diabetes. You know the ominous octet of Ralph DeFronzo at the beginning? Many years ago when I was starting, it was just insulin deficiency. Somehow it emerged insulin resistance, and that's it. Now we have 8, but there are even more these pathophysiological defects in type 2 diabetes. So probably to discover some new of them and to target them with new medications.
Thank you very much again for the question and the answer. Are there other questions? Any other questions from the audience?
I would like to ask maybe a final question. I wanted to know what part of the guidelines, in your opinion, is most outdated? Which part needs an update as a first line?
You mean in the current consensus report?
Yes.
This current consensus report? Yes, which is most updated? I would say that it was the pharmacotherapy one, because there were new medications and new evidence from new therapeutic options, from the cardiovascular, from the renal outcomes, and from the heart failure outcomes trials. And I was responsible for some of the old drugs, for metformin, for SUs, for TZDs. It was hardly something to find there, something new. There were some publications, but not that many. While with the GLP-1, so with the SGLT2s, and just to share with you, the dual GLP-1 GIP receptor dual agonist was approved in the United States in May, just in the period when we were preparing the presentation for the ADA meeting. So we had to include it, as it was already approved, and it was thereafter approved for Europe later on, some months later. So we had to have this dual agonist there, and just to be on time with including it in the guidelines. Otherwise, it would have been missing there, and it appears to be quite important now. So it was a very dynamic process because new information was emerging, was coming out from the trials, and really this part was most updated from the 2018, and all the infographic and the table. A great emphasis was put on social determinants of health. They are nicely outlined there, but this is this part for the therapeutic options.
Thank you. And as for now, what part would be updated in the light of current guidelines?
We need to go through the whole report to see whether and because you do not know what to update, you just have some impressions, but when you go deeply through hundreds and thousands of papers, then it can clearly be seen what is new, what has strong evidence there, and then we can decide. Of course, we will not repeat all what is written there. Of course, it will be an update, but I'm sure that probably it will be as interesting as this one. But for sure, if we are speaking on this now, and if we speak about this next year, just before the presentation at ADA, probably a lot of things would have changed during this 1 year ahead as well.
Thank you very much for the answer. Do we have any questions left? No.
I think, yeah, we are almost also reaching our time limit. So with that, probably we can thank once again to Dr. Tankova for this very nice presentation and very valuable discussions after that. I would like to thank the participants also who contribute to these discussions with their questions. And we would like to see you in our next webinar also. Then with that, I would like to end this webinar session. Thanks again for everyone.
Thank you very much for the invitation, and it was a great pleasure for me.
Thank you again.
Thank you.
Thank you very much.
Bye-bye.
Bye.